Let us open this webinar now then. Good morning, good afternoon, good evening, and a warm welcome to all of you who have joined us from all around the world. I am Carsten Engel, the CEO of ISQua, the International Society for Quality in Healthcare, and ISQua is proud of partnering with the WHO to arrange these global quality rounds. They are so well aligned with the tagline under which we work: knowledge, network, voice, and action. We know that quality of care is an inseparable part of universal health coverage, and we know that the quality of care, unfortunately, is not everywhere as good as we want it to be. Poor quality care is responsible for millions of deaths in low and middle income countries, accounts for up to 15% of overall deaths in those countries, but also in high income countries, 1 of 10 patients is harmed while receiving hospital care. So there's a good reason for us to join together and learn from each other. The purpose of these quality rounds is to enable us to share experiences, knowledge, and ideas related to the quality of care and disseminating these lessons learned across the world. It is also an opportunity to challenge each other on the shared experience and thus refine the collective thinking we have about quality of care. And finally, it should hopefully also spark the generation of new practical ideas that support the efforts to enhance the quality of care. Today, in this third WHO Global Quality Round, we'll explore the catalytic role of health partnerships, working together across boundaries for shared vision, motivation, joint planning, and action to help deliver quality improvement within healthcare systems. We will explore 3 examples: one example of a national twinning partnership, one example of a multiple level partnership, and one example of a south-to-south partnership. It will be exciting, and I look very much forward to listen to and learn from these examples. Now over to Oriane to present the individual examples and to guide us through today.
Thanks a lot, Carsten, and greetings, everyone. Before handing to our dear speakers to explore the catalytic role of health partnerships to help deliver quality improvement within health systems, I would like to take a few seconds to remind ourselves of the opportunity offered by these WHO Global Quality Rounds co-hosted with ISQua. The quality rounds provide a virtual forum to highlight the critical role that quality of care plays in strengthening health systems and improving health outcomes. Today, as Carsten was saying, colleagues from within health partnerships across the world and at different levels of the health systems are coming together to share learning through the experiences, challenges, and successes. Health partnership working provides an opportunity for people to work together and learn from each other to support long-term efforts on quality of care. The WHO Twinning Partnerships for Improvement model is based on a doing while learning approach in which the collaboration, co-development, and sharing of knowledge are key elements. WHO supports institutions in establishing strong relationships, implement effective improvements, and spread the learning across local, regional, and national health systems. Our first partnership that we'll be hearing from today is between 3 countries, Malawi, Scotland, and Zambia, and has commenced at the national level. Unfortunately, Dr. Mbewe from the Ministry of Health and Population in Malawi is unable to join us today. I'm sure that you are all aware of the cyclone that hit Malawi recently, and our thoughts are with Dr. Mbewe and his teams, as well as the healthcare workers and people of Malawi during this time. Ms. Clevina Mizenda and Professor Jason Leach are representing today the Quality Improvement in Global Health Partnerships program between Malawi, Zambia, and Scotland.
My presentation will look at the overview of the key activities of the Quality Improvement Partnership, how the partnership started, the benefits that we are seeing from the partnership and the lessons that we've learned, as well as the recommendations that can be given to other people. about embarking on some partnership. The key activities of the partnership mainly are in two thematic areas. The first thematic area is capacity building, where we're looking at training in-service health workers in quality improvement principles so that we can build that capacity of our health workers. We're also looking at collaborative learning, realizing that most quality gaps are actually similar, so that we promote the collaborative learning and the collaborative tackling of the quality problems. Also, under capacity building, we're also looking at having some e-learning QI training package, which can be useful instead of the physical training. We're also looking at continuing with the best practices sharing through the QI conferences, which we hold annually. So for QI conferences, we actually decentralized to the provincial level, where those are the first one to hold. Then from the provincial levels, the winners of the provincial level QI conferences are the ones that are selected to present at the national QI conference. So the other thematic area for the key activities of the partnership is the patient safety agenda. The planned activities under this thematic area is the adaptation, domestication, and implementation of the Global Patient Safety Action Plan, which started in 2021 and is running up to 2030. Apology for that mistake. It's actually supposed to be 2030. Development of patient safety tools, the ones that can be used by the clinicians so that they are able to see things from an improvement model. Then the development of in-service patient safety training modules, something that we need to standardize. We need to check at what do we have and how do we standardize and have what we call patient safety training modules. Then as well as commemoration of the World Patient Safety Day, which falls on the 17th September annually. So how was the partnership formed? It started with the Scottish Government, the Global Health Coordination Unit, that approached the Ministry of Health through the Department of Quality Assurance and Improvement about the idea of having a partnership on quality issues. So meetings were being held. Some meetings I remember were held via Zoom, some WhatsApp calls from the coordinating person on the Scottish Government, and sharing of ideas actually started slowly, but eventually it peaked. We started communicating, and later on, the coordinator from the Scottish Government introduced the Malawi team. So now the partnership actually took place or took shape, and meetings now started being held on updates from each country, what each country was doing regarding quality improvement, quality assurance. So through the discussion, there was also an agreement to say we need to start having the exchange visits. And the first visit that was planned was to attend the International Forum on Quality and Safety in Healthcare in Gothenburg in Sweden. But then this couldn't materialize. There were issues that led for this not to really happen, especially the visa issues. And at that time, the coordination from the Scottish Government actually changed hands. From Emily, then Dr. Kalonde took over the coordination. So I would say a lot has actually happened with the partnership agreement now being put in place, as well as we are actually having some funding proposals. When it comes to also the coordination, we agreed to be rotating. We started with the Scottish Government chairing and coordinating all the activities. But for this year, 2023, it's Malawi that is coordinating or chairing the partnership. It's rotating, and then next year it will be Zambia that will be chairing the partnership. It has helped to, so how has the partnership been used to drive quality? It has helped to understand how our partners are actually championing the quality and the patient safety agenda. There are some issues that we were not really so confident, but from the meetings that we've had, we are actually able to say, oh, our friends or our partners, this is what they're doing. Maybe even us, we can actually try to tackle things from that angle. In short, the partnership is also helping us to redesign our approach from what we are learning from our partners. When it comes to resources, I think it's bringing all components of support, starting from the technical up to the additional financial support from the funding proposals that we actually submitted. So, concerning the learning or the key learning lessons that we have learned from this partnership, we've learned a lot, but I would actually single out the one that looks at how, if we want to sustain quality assurance or quality improvement, that we are not supposed to actually handle it single-handedly as the Ministry of Health, but we need to consider bringing on board other sectors that contribute to the understanding of health. I think the way we learned in Scotland is that they are actually working close with the education sector. And I can say that actually the other challenge that we have as a developing country are issues of literacy. And we all know that literacy affects implementation of some activities or assimilation of the health information. What would be useful for other people to hear about? I think I can only say that partnership model is beneficial in program implementation, as you learn a lot from the others. It promotes that learning of best practices. There could be some things that you are implementing as a country or as a program where you think you are doing the best, but when you learn it from others, you realize that, oh, you needed to do A, B, C, D. In short, partnership brings actually new perspectives or new ideas. It just broadens the base of skills, knowledge, and expertise. So all I can say is partnership are beneficial. They really help us to understand and be able to apply even best practices that have been implemented by other people. So thank you very much for this opportunity.
Thank you, Clivina. It was great to hear about how the partnership developed and the key activities and learning. Professor Leach, may I turn now to you so we can hear your experience and thoughts of the partnership.
Thanks, Oriane, and hello, everybody. It's wonderful to be here. What a wonderful list of countries in the chat box. We really have east to west fully covered. We have South America and Africa and East Asia, and we even have Scotland. And I am here with, I think, another couple of Scots in the crowd to keep me company. It's wonderful to be part of this. It's also wonderful to hear that story from our partner, one of our partners, and I genuinely don't have a huge amount to add to that complexity and complete description of what we've done here. I was asked to answer 3 questions, which I think have already been answered a little, actually, but let me give you the Scottish perspective on how we got to here and what lessons we would learn to continue. So we got to here over a very long period, in fact. I have been in this job for a number of years, and I've spoken to particularly the Malawian quality leads over probably about a decade, including the Malawian Health Secretary, the Malawian Head of Quality, the Malawian Director of a variety of quality meetings around the world. It didn't really become anything real until we had a WHO connection. And like all things in life, it is relational. It is about people meeting other people. So a number of stars aligned, including a Scottish person who may well be on this call, Matthew Nielsen, going to work at the WHO and having the ear of those who could then perhaps convene us in a more meaningful way. And I think Matthew may speak a little bit later on. So initially, we had Malawi and Scotland, but Scotland, small but perfectly formed, has a small global development budget. And therefore, we choose very carefully how we use that global development budget. And one of the things we do is limit the number of countries that we help and partner with. So therefore, when you start to work with Malawi, it turns out you probably should also work with Zambia. So that's how we ended up in this grouping. But it was crucial, and this goes to the second question, how we have tried to drive quality. It's been absolutely crucial not to spare their blushes, but it's been crucial that the WHO have been a kind of neutral convener for us. That may not always be required, but for us, that was very, very important. We brought people together in virtual roundtables because COVID was still going on, and we gathered as groups, we got to know each other. The WHO convened those meetings in the first year. They were led by Shams Syed, they were chaired by Shams, who was, this isn't his right title, but kind of head of quality at the WHO and universal health coverage. And then Scotland took over in year 2, and now Malawi has taken over in year 3, 2023. So we've tried to make the convener different each of those times. We initially, of course, just shared what we had in terms of infrastructure, what our country priorities were, what our challenges were for each of the 3 partners. And that allowed us to see where we had areas of similarity, areas of learning, perhaps areas we could share that would help the other 2 countries in all of that triad. And we shared examples of best practice. It became clear quite early on that one of the things we could do together was what's right in the middle of this single slide here, and that's the 3rd Global Patient Safety Challenge, which is about, as you all know in this room, that was about medication. And we had people who were working on that, so did Malawi, so did Zambia. So we were able to bring everybody together to think about working on that together. And that was where we started to do some capacity building. We had a pharmacist in Scotland who was leading our work, who was bringing people together. So all of that was able to work together. And I've written on my little note here that that was actual work. I'm not sure if that translates into all languages around the world, but it was more than just talking, and it was more than just meeting. It was getting on with actual work and doing it together. So much so that that has led to dissemination of that work through posters at Quality Improvement Forum. The BMJ IHI Forum in Copenhagen will have some of this partnership work displayed in the scientific poster display. My third question was, what have you learned? And in brief, I've learned exactly what my colleague just described, lots of those same lessons. For us, and this lesson may not be applicable to everybody, but for us, the WHO were crucial. So having a neutral convener at the beginning, I think, was very important. Equality was very important. This isn't a global south versus the global north or the other way around. It's not the north telling the south what to do. Equally, it's not the south telling the north what to do. It is a partnership of equals. We are good at some things. We're not good at everything. Malawi are good at some things. They're not good at everything. So it's important that everybody spends time learning what each other are able to help with. It also takes time. It felt slow, and it still feels somewhat slow, but I think you have to invest that time for the end reward. Face-to-face is better, and getting to know each other online is absolutely fine. But when we convened the first real in-person meeting in Scotland, I felt as though we began to accelerate the change and the work together, because we were able to eat together, we were able to go to the restaurant together, we were able to meet in the one room together. Like all things, it's always about those relationships. And we're looking forward to, we hope, having our second in-person meeting in Malawi in the second half of this year. And my final lesson is you don't really learn unless you're actually working. So you have to actually do something together. Now, it may take you a little bit of time to get to that point, but once you choose what it is, you have to, in English language metaphors, you have to get your hands dirty. So you have to actually do the work that you intend to do. So those are my lessons. Get a neutral convener, make sure it's equal. It takes time. You need face-to-face as well as online if you possibly can, and do actual work together. And I think that's what we've learned in Scotland, Oriane. Thank you for listening.
Thank you very much to both of you for the very interesting insights you have provided. I will now turn to King's Somaliland Partnership, represented by Dr. Kathy Reid and Dr. MD Issa.
So our presentation describes a partnership project that ran between August 21 and May 22. We will cover the background to the partnership, our multi-level approach to quality improvement that leverages expertise of all the partners, our reflections on how the partnership has driven quality of care, and finally, key learning from the partnership that is informing the next phase for this work. King's Somaliland Partnership has been working in Somaliland since 2000, with a current focus on health workforce, quality of care and research. Somaliland Ministry of Health and Development identified quality improvement as a priority for this latest collaboration. This initiative has drawn on WHO's Taking Action approach to quality improvement in FCV settings and the associated technical package. We felt this guidance was highly relevant to Somaliland, which has the 4th lowest GDP globally, ongoing regional conflict, and multiple humanitarian and health challenges. The partners included the Ministry of Health and Development, King's Somaliland Partnership, staff and volunteers, WHO, and involved a regional hospital and health centre cluster. So we set out to model a whole system approach to quality improvement, engaging with primary care, a regional facility, and the national level. At national level, we developed a situational analysis on quality of health services. We assessed Boroma Regional Hospital and 8 community health centres using WHO's patient-friendly safety hospital framework and a similar primary care tool. We identified infection prevention control as a priority for intervention through a blended approach that strengthened governance structures, built staff capacity, and improved the facility environment. We aim to generate evidence, strengthen capacity to improve quality of care, and to improve systems and processes for quality and safety. In this model, evidence informs quality of care initiatives prioritised, and learning from implementation informs national strategy and future rollout. Although originally planned as a 3-year project, due to funding constraints, this was run as a pilot funded by the UK Department of Health and Social Care through the Tropical Health Education Trust THET. So, how has the partnership been used to drive quality of care? First, briefly on what we achieved. At the national level, there are foundations of an evidence base on the current situation that clearly identifies opportunities and challenges. National health leaders have increased their understanding of quality improvement and made commitments to the quality agenda. At the regional level, there is improved capacity, and to work on quality improvement and clear progress in IPC practices at the target health centres and the regional hospital, which moved from a rating of inadequate to intermediate during the project timeline. We have tried to unpack what the partners brought to the table. Commitment and leadership of the Ministry of Health and Development and system health leaders was a major factor. The partnership's ability to make connections and get things done, WHO's roadmap and evidence-based tools and supportive guidance, and the expertise of our volunteer colleagues from the Quality Improvement Unit at South London and the Maudsley NHS Trust. We think also 3 facilitators are very important. The longevity of our partnership, having adequate project management capacity, and taking a multi-level approach. So handing over to Hamdi to consider the learning points.
Good afternoon all. I'm Dr. Hamdi Issa and I'm currently based in Somaliland, where I'm the Director of Community Health Services. And I was the Somaliland focal point for the Quality Care project. I'm going to take you through the final part of our presentation, exploring what has been the key learning for this partnership. With any partnership, it is important to take some time to reflect on the key learning that we can take forward. Fortunately for us, we have managed to secure some more funding to scale up this quality improvement work into a wider project that will support the national scale up of the quality care agenda in Somaliland from multiple levels. But as a way of summary, we can group the key lessons into 6 main themes. This is in no way an exhaustive list, but what we felt are critical ingredients to quality care, especially where you leverage partnership modalities to facilitate knowledge exchange and change. So 1, catalyst to change has to be localized. Grassroots localized movements are critical to affect change. In the case of Somaliland, the quality agenda, even before this project, and what helped make this project successful, was the grassroots movement of a committed group of local civil servants that were and continue to push for the health system strengthening narrative in Somaliland to be centered on quality care. This has prompted the necessary sensitization to senior management, including ministerial level, where the Minister of Health and guiding Somaliland health strategic documents are advocating for the importance of quality care in all health programs. Number 2, small changes can lead to wider improvements. It is easy to focus on and be overwhelmed by the big ideas. But when starting an ambitious HSS initiative, we need to leverage low-hanging fruits to catalyze wider improvements. By conducting the first national situational analysis on QI in Somaliland, what we consider as one low-hanging fruit for this project, it allowed us to undertake a quick assessment of the current quality care situation in Somaliland and map the wider challenges and potential solutions. We found the situational analysis really helped catalyze broader interest and appetite amongst ministry colleagues working in and full service delivery to consider quality improvements in their work. And it paved the way for a call for national scale-up and need to develop a national quality strategy that can guide the broader QI ambitions. Lesson 3, health system change takes time and needs investments over the long term. This project was short and had limited funding, but we know how health partnership working is relational and how system change is complex. So bringing together multiple partners across countries and designing tailored interventions really needs sufficient time for planning, for project governance, for decision-making to achieve system-level change. Number 4, how system change needs to be owned and driven by local institutions and their stakeholders. This key lesson has synergies to the first key lesson, but now looking through the lens of the facility level. We know that changes on quality need to be driven by health system leaders, and the role of health partners should be one of a supporting role. Projects that leverage health partnerships and that implement interventions at facility level need to invest in modalities that can secure buy-in from senior leadership at these health facilities, to ensure activities are locally led and that they continue even after the project ends to sustain project gains. Number 5, capacity building of individuals needs to be linked to health system development. Training should be delivered with the expectation that knowledge gained will be applied to health system improvement and is more effective when delivered with mentorship and supportive supervision. Number 6, NHS volunteers. Our final lesson is centered on NHS volunteers. Partnerships that rely on high-income country, low-income country modality, where in this example, for the training sessions, we were predominantly drawing on volunteers from the NHS. What we saw was that the current pressure on the NHS meant we needed to recruit from a larger volunteer pool. We need to find ways to be able to share work between groups of volunteers to prevent burnout and maintain the retention of these key volunteers. And that draws to the end of our presentation and the summary of those key lessons. Thank you very much.
Thank you very much to both of you for such interesting talks.
So
I would like now to welcome the full team from Project AJAYU between Cardiocentrum and Brown, Mexico, composed by Dr. Alexandra Eat, Dr. Isidro Gutierrez, Ms. Ana Marie Sanrinen, Dr. Oscar San Roman, and Mr. Pablo Freudenthal.
Good morning, good afternoon, good evening. Thank you very much for inviting us to WHO and ISQua. We will be talking about universal neonatal cardiac screenings and how these can reduce newborn and infant mortality, drawing on our best practice from a Mexican-Bolivian partnership that has been running for 6 years already. Very nice to meet you. My name is Pablo Freudenthal. I am here with Alexander Heath, representing Project AJAYU at Cardiocentrum, Bolivia's leading clinic for pediatric cardiology at high altitude. We have the honor to be joined by Dr. Isidro Gutierrez and Dr. San Roman of the Mexican chapter of the Born Project, which is docked at Universidad Autónoma de Querétaro, as well as Ana Marie Sanrinen, the head of the Global Newborn Foundation and Born Project. Thank you to our institutional partners, and with a special mention to Jimena Loma of the Ministry of Health of Bolivia and Ana Crespo of the GIZ. Thank you very much for the whole team at Cardiocentrum and Hospital Holandés for making this project happen in Bolivia and gaining first evidence of congenital heart disease at very high altitude, above 4,000 meters above sea level. So how has our partnership been used to drive quality and care? By jointly campaigning for universal neonatal cardiac screening. The key activities of our partnership were sharing scientific evidence, collaborating on capacity building, supporting each other's efforts to steer policy. It was formed by our common tie, the Global Born Project, as well as interpersonal interactions at conferences, while traveling offline, online. We argue that newborn mortality will be reduced with congenital heart disease screening if international organizations such as the WHO and ISQua update their newborn care guidelines in order to include pulse oximetry screenings, especially those sensitive to altitude and demographic indicators. Then governments in developing countries will be able to prioritize this area better and sign laws for universal implementation of neonatal cardiac screenings. On a facility level, what needs to happen is that establishments need to be encouraged to share data in order to increase the value of the common pool and enable higher diagnostic accuracy via shared reporting tools. If we do this, healthcare workers will be empowered as decision makers and no longer burdened with the bureaucracy that goes hand in hand with implementing a new tool like this. In order to sustain these hypotheses, we will draw out what we understand as quality in the care for congenital heart disease, share a brief perspective onto Bolivia and Mexico, then switch to our learnings from our common collaboration measures, and then share with you our evidence on neonatal cardiac screening in El Alto in Bolivia. Finally, presenting to you an outlook and recommendations for policy action. So campaigning for congenital heart disease is not easy. If we look into the incidence that is reported by European studies, by studies at sea level, we only see 1%, and this is not convincing enough for stakeholders in developing countries to prioritize this area. But we need to bear in mind that the data is vastly unexplored in developing countries, in low social development countries. So this leads to a higher mortality related to CHD. What we do know, however, is that the share of congenital heart disease in all infant mortality is growing year by year. And this is the case in all but the richest countries. So if we take a brief look at these curves, we see that all of the lines have a tendency of growth, except for the red one, which is the richest countries. We need to focus on the green one, which represents low middle SDI countries like Bolivia, and the blue one like Mexico, where we see that there definitely is a tendency for growth. We need to bear in mind that congenital heart disease are not only the most common defect at birth, but are also the most lethal. Congenital heart diseases are a group of heart conditions that are present at birth and arise due to abnormalities in the structure and function of the heart. And they are mostly tied to genetics and environment. For instance, we know already that there is a higher incidence at higher altitude. However, most defects are treatable if detected early. Now, for about 20 years already, literature has identified that pulse oximetry is a very effective complement to physical examination in order to screen these children and find these more efficiently. Nevertheless, screening needs to be complemented by follow-up echocardiography scans. And this is what makes things tricky, because we do rely on specialists, on pediatric cardiologists, in order to conduct this last diagnosis here. So what do we mean when we say we want to improve quality in congenital heart disease care? Well, first of all, timely diagnosis and therefore timely screening right at birth. On a national level, we need political commitment. We need laws that sign off universal neonatal cardiac screening, such as has been done in Mexico. We need solid referral systems, also on a subnational level, that will include all of the relevant information that needs to get to the specialists. We need capacity building for the entire workforce, not only for specialists, but also for the nurses, for the public health workers in the hospital. Everybody needs to be engaged and aware. And lastly, we do need to communicate better with our communities. Especially in our cohort, for instance, in Bolivia, we have 20% migrant dwellers from rural areas that will ultimately rely on relatives for the care of the newborn, because they have no immediate touch points with the medical system in their hometowns. So why exactly do we look at Mexico in order to seek for orientation regarding our progress on congenital heart disease in Bolivia? Well, first of all, because we have a very rich body in evidence on people living above 1,500 meters above sea level. This is also represented in the scientific evidence that Mexican researchers have conducted. Here we see there's evidence of over 40,000 children with screenings and corroborations conducted to date. There's also a very large body of expertise, many specialists, and lastly, it is a very interesting thing to note that newborn mortality in Mexico forms such a big chunk of overall infant mortality, which is why there is a special policy focus on reducing newborn mortality. And this is very inspiring to us to see as well, because ultimately we will get there in Bolivia as well. Now, Mexico is a few steps ahead of us. Here we see the progress we've seen in Mexico, for instance. First comes evidence. You need to provide evidence in order to convince policy stakeholders. In Mexico, there has been a decree already signed for universal cardiac screenings in 2022. This step is still ahead of us. Then, however, you need to implement it in the facilities, in the hospital systems, and you need a solid reporting system, which is something that we are both walking on the same path, both Mexico and Bolivia, and we hope to learn from each other and gain some leapfrogging. Now, this is what I was referring to. The cutoff for pulse oximetry screening in Mexico is sensitive to altitude, which is very interesting to us. However, it must be said that the Bolivian evidence has also inspired this decree. So our evidence is also relevant to the Mexican case. Nevertheless, it is very inspiring for us to see that Mexican clinicians count with guidelines on how to proceed with newborns saturating at lower levels than the cutoffs. And there is also a template for a unified reporting system. So what has been the key learning from our partnerships? Well, first of all, the methodical approach to it, that policy will follow evidence. Here we see Dr. Isidro together with the Mexican parliament is signing off the decree with the team. And that is very inspiring to us because there seems to be a sequence. It's not a sprint, but it's a marathon. Here we see Dr. Alexandra Heath in Mexico, also sharing clinical knowledge with the scientific teams in Mexico here in Querétaro, and also championing on new innovations, running on diagnostic capacities here with the Newborn Foundation and the Bloom Standard. Now, what we can say regarding capacity building in a South-South partnership is that it bears considerable benefits because we share one language. We in Bolivia are constantly exposed to Mexican content, be it medical Mexican content on YouTube tutorials, etc. So if we conduct Zoom trainings with specialists in Mexico, this knowledge is much better integrated into practice, really. And this is why I need to stress that more competence, we would argue, should be given to South-South partnerships within a common cultural tie. Now, looking into the Bolivian case, I just want to say 3 things here. So we know already that a very high percentage of our children are born at very high altitude, and we have alarming figures for newborn mortality here, among the highest in the region. Also, we only count with 1 facility nationwide that is able to treat newborns with congenital heart disease, which is Hospital del Niño in La Paz. So we really need to make sure that we have very solid screening and referral systems to optimize for the use of this very valuable human resource. In order to do so, we have conducted the country's first ever a very high altitude congenital heart disease screening validation. So what we did was to go up to a peri-urban hospital in El Alto, which is at the outskirts of La Paz, and screened 1,009 randomized newborns with a pulse oximetry and corroborated these values with echocardiography with our specialists. So this implied teamwork. We worked with the staff at Hospital Holandés, so they would fill out. We trained them to fill out a signs and symptoms sheet, conduct oxygen saturation screenings, and enter the data into a common platform. Further on, one cardiologist and an assistant would travel to the hospital and corroborate these screenings, as well as completing the history of the patient on our platform. Here you can see the signs and symptom screens which we did digitize, as well as general indications on what would show an at-risk newborn. As you can see, newborns at high altitude show lower saturation levels, which is why we needed to make sure to identify a cutoff for 4,000 meters above sea level in El Alto, Bolivia. So what we found was quite alarming. We found an incidence which was about 5 times as high as at sea level, at 4.9%, which represented 50 out of 1,009 patients, with 9% severe cases even. For now, we will state that our recommended cutoff for pulse oximetry screening is 90%. However, we are still applying different algorithms to our data, and will include our complete recommendations in a peer-reviewed article. Now, we also found 75 patients with pulmonary hypertension, which were in need of supplemental oxygen. This is also quite scary if we think about that these kids could have not been screened during our intervention and would have potentially been at risk of suffering sudden infant death back at home. Now, as on a system level, what we did learn was that addressing Hospital Hollandais as an intervention site was very effective, a para-urban maternity, as it was, it led to a very high incidence and ultimately high impact. However, there were certainly challenges there because of data process challenges, as well as training the workforce, and ultimately also taking into consideration that we are dealing with an overall socially very fragile community. A very high degree of our patient moms were teenage moms, and we also had a high percentage of rural dwellers. Now, the way we look forward is that we don't want to stay in our data silo, and we don't only want to stick to academics. We want our screening protocol to be integrated in the National Medical Digital Patient Record, the SUIS. And we want to expand our project nationwide to para-urban hospitals nationwide. And in order to do so, we will need to equip coordination centers, hospitals, as well as support with human resources. We argue that newborn mortality will be reduced with congenital heart disease screening and pulse oximetry screening, because it is an extremely efficient triage method, not only for CHD, but also for pulmonary hypertension, in our case totaling more than 10% of all kids showed a considerable complication. And it is also a very valuable monitoring method in order to track an intervention. Here, because we are inducing data into the digital health record at a very early stage, which makes it easier to track success. And we estimate that we can, in Bolivia and in developing countries which lie at high altitude, which is over 100 million people living worldwide, that we are addressing here, we expect to reduce newborn mortality by up to 50%. Now, ultimately, what we would ask the community here to encourage, what we would encourage the community here is to discuss the option of updating newborn guidelines. For example, the WHO guidelines of newborn care of 2017, with a sensitivity of pulse oximetry screenings at a high altitude and considering different demographies. We would urge governments, especially in high altitude regions such as Bolivia, to sign decrees for universal neonatal cardiac screenings and provide the resources. We would encourage hospitals to enter into partnerships for sharing data and enabling higher diagnostic accuracy here, drawing on innovative tools that are ultimately fed by data. And ultimately, we wish for the healthcare workforce to be empowered as decision makers and fully carry on this great mission of integrating children, of integrating even children with congenital heart diseases into our societies and see them flourish. Thank you very much for your attention. I encourage everybody to stay on for the breakout session, and I am very happy for any feedback that you may have. You may contact me if you wish, or you can also check out the website to access further resources on the topic. Thank you very much and have a lovely week.
Thank you very much to Project Ajayu's team, and in particular to Mr. Pablo Freudenthal for this brilliant presentation. I would like now to give the floor to my colleague, Ms. Katiana Aparicio-Reyes, who will be presenting the content of an advocacy brief that has been developed in the team of Training Partnerships for Improvement, Building Quality Health Services for COVID-19 Recovery and Beyond. Katiana, over to you, please.
Yeah, sorry. Good morning, good afternoon, and good evening, everyone. And thank you very much for the opportunity to present this advocacy brief that will be released in the upcoming weeks. So no need to remind you that the COVID-19 pandemic caused untold disruption on health systems at national, district, and facility levels around the world. During this period, many institutional health partnerships have worked tirelessly since the early months of the pandemic to support preparedness and response. Having witnessed all these efforts, we are convinced that institutional health partnerships can support the recovery efforts and contribute to building back better of quality health services. The objectives of this advocacy brief are three: help countries, governments, and individuals operating at all levels of the health systems to understand the utility of the WHO TPI approach as a mechanism for improving the quality of care during the recovery phase of the COVID-19 pandemic or even other health events of this nature. To help mobilize the global health partnership community to support the application of the TPI approach and continue to learn. As you have seen, it's all about learning, sharing, and learning. Help leverage the power of partnerships as a driving force for quality, for developing and sustaining quality health services. So how this advocacy brief was developed? This advocacy brief draws on reports of various activities carried out from 2020 to 2022 by the Global Health Partnership community. We selected partnerships that initiated their activities in 2019 or 2020. We also focused on those partnerships that adapted their implementation plan or activities to respond to the pandemic. And finally, we focus also on those partnerships that proposed innovative solutions to overcome restrictions and challenges. So, what is the added value of this advocacy brief in the context of COVID-19 and recovery and beyond? Based on the experiences of many partnerships that have operated during the acute phase of the COVID-19 pandemic, we note that despite the disruptive effect on health service delivery and on partnerships themselves, the twinning partnerships have continued to play an important role in responding to the pandemic and in maintaining essential health services. So the added value of the TPI approach resides in the flexibility, the adaptability, the solidarity, the capacity to provide rapid responses and innovative solutions. With this advocacy brief, we want to make the case for institutional health partnerships. The experiences we gather allowed us to stress in this advocacy brief how our TPI model can be adapted to support the COVID-19 recovery. In the advocacy brief, we go in detail through the three objectives, which are partnership development, improvement, and spread, and then a step-by-step of the TPI cycle. Our call is really to tilt institutional health partnerships to co-develop solutions for immediate needs in the current phase of the COVID-19 pandemic and beyond. Leverage the power of partnerships between individuals, institutions, and countries for necessary action. Application of the TPI approach as a driving force for quality of care with a specific focus on action at the point of care. And just to finalize, I would like to share with you a quote from a partner that, to my sense, summarizes or describes very much the partnership spirit. So just leave you a few seconds for you to read it, and would like to thank you for your attention. Thank you very much.
Thanks a lot, Katiana, for this very interesting presentation. May I now turn to my colleague, Ms. Asia Odugle-Kole, for reflection on what has been shared by our speakers. Asia, over to you, please.
Thank you, Orion. And we've had 3 really excellent presentations. So I've got a really difficult job of trying to capture the essentials across all 3 presentations. I've got lots of notes here, and I don't want to repeat what's already been said. But I think what I'd like to do is just touch upon some of the key themes that were coming out from all 3 presentations. And the first thing that struck me was that this notion that it's about people meeting people, that partnerships are around the importance of relationships and the relational dimensions of partnering. What I heard was that it's really important to have a concrete focus and an anchor to the partnership itself. Being very clear about what do we want to do together and what difference do we want to make together, and how. We heard from Mexico the importance of using data and evidence to drive those discussions around what are we doing and how do we do it. We heard from Somaliland and the UK the importance of looking at the whole system from leadership right down to the local level, and the commitments required at all of these levels. The importance of having a convener and a facilitator. So not only when we're addressing quality are we convening and connecting different levels of the health system and different parts of the health system, but also the partnership itself and the partners need connecting and convening. And so is that done internally, or is that facilitated by an outside partner such as WHO? We heard from Malawi that the partnership itself contributed to innovation, and that it brought new ideas and learning. We heard that the core essential ingredients of a partnership for quality, the how-to, the methods, the approaches, the processes. The importance of sharing that leadership, ensuring that those in partnership with each other are able to listen to each other, hear each other, and be able to take leadership where they excel in, because each partner will bring different perspectives and experiences and expertise to the partnership itself. But I also want to recognize that partnerships are not easy. And a number of the speakers referred to this being the long term. We are in it for the long term. It's not something that is entered into for short-term impact and outcomes. That where cross-boundary work is concerned, not only are we looking at institutional values and institutional resources and institutional expertise, but it does cross different cultures. So north-south, south-south, north-north, all of these different partnerships become unique because of the uniqueness of the partnerships that are coming around the table to work together, and the uniqueness of the individuals that make up the partnerships themselves. And I think this then really refers to the quality of the partnership itself. So not only is it what quality dimensions are being addressed, but also paying attention to how the partnership itself evolves over time, and the quality of the interactions, the quality of the decision making, how resources are used, the ability to be able to, as the partnership progresses, to learn from the doing together. So making sure that results are being achieved, but also paying attention to how those results are being achieved. We heard also that learning crosses all dimensions, and that what was interesting for me actually was when Somaliland was talking about the situation analysis and how transformative that situation analysis was. That there was something about how the situation analysis was done that was important. So what I'd like to urge you to do, and it's really good that we have the breakout sessions where you can talk to the speakers and dive deeper into some of the experiences and learnings that could not have been covered in a 5 to 8 minute presentation. But often it's the how things happened, what led to certain kinds of decisions being made that is interesting and is actually contextual. And I think it's really important to really begin to unpack the contextual and the relational dimensions of partnerships. I think that all of the presentations address the issue that when we address quality, we're looking at systemic interventions, that it's not just one. You start with an entry point in one part of the healthcare system, and then you impact and influence other dimensions of the healthcare system. So the importance of paying attention to who is sitting around the table, having a clear idea of the roles and responsibilities of each of the stakeholder members. Are the right people from the partnership sitting around the table? Who is not sitting around the table, and whose voices need to be heard? Is it clear where expertise lies, and how can that expertise be accessed? And I think also what I want to close on before we move into the breakouts is this whole notion of the relationship between each of the partnership members themselves. Is there trust? Is there compassion? Is there kindness? Does the partnership embody the values and the ways of working that the partnership wants to see in the work that it's doing? I think that there's a lot to unpack, and we've had 3 really excellent presentations from which to sort of dive deeper. And I'd really like to sort of encourage you in the breakouts to ask questions which challenge and spark new ways of thinking about how quality is addressed from the people that are actually doing it on the ground. So thank you, and thank you for the opportunity to offer some of my brief reflections, and thank you to all of the speakers.